Deborah Roach is Director of Continuing Education and Workforce Development at Penn State University, serving the Beaver and Shenango Valley campus area. Dr. Roach has professional experience in the areas of strategic education planning, curriculum development, workforce preparation, and 21st century workforce demands. In addition to her experience in higher education, Dr. Roach has an extensive professional career in business, private industry, and with nonprofit agencies. Her educational credentials include a PhD in Instructional Management and Leadership, MBA, and a BS in Human Resource Management. Our next panelist, Michael Wright. Michael served as the President and Executive Officer of the Shenango Valley Urban League for 10 years, retiring in August of 2015. Previously, for 22 years, he was the Executive Director of the Community Food Warehouse of Mercer County, a nonprofit food bank affiliated with the national organization Feeding America. Mr. Wright received numerous awards, community service awards, including NAACP Image Award and the Paul Harris Fellow Rotary International Award. He is a current board member of the Farrell Planning Commission. He served on boards of Laurel Technical Institute, the Farrell Area School District, Board of Education, the FEMA Board, and State Food Purchase Board of Mercer County. He holds an MBA from Geneva College and a BS from Point Park. His motto for success is, "Do not go where the path may lead. Start your own path and leave a trail." Next is Marianne Daniels. Marianne is the Chief Executive Director of the Mercer County Behavioral Health Commission. The Commission serves on behalf of Mercer County for integrated mental health and intellectual disability administration, intake, case management functions with a staff of 100 persons and an annual budget of $12 million. Ms. Daniels previously served as the Executive Director of Erie County Office of Children and Youth, Director of Mercer County Human Services, and Human Services Associate Director of Crawford County Human Services. She earned a master's degree in education and educational school psychology and a BA in early childhood education and psychology from Edinburgh. And last, Dr. George Garrow. Dr. George Garrow is the Chief Medical Officer of Primary Health Network. Primary Health is a federally qualified health center that has offices in 16 counties, and their headquarters is in our Shenango Valley. Previously, Dr. Garrow was the Medical Director of the Oncology and Director of Hospice of Sharon Regional Health System, and he was also the Chief Medical Officer, Western Maryland Health System. Dr. Garrow earned his medical degree from Penn State University College of Medicine, Milton Hershey, and a BAS from the University of Pennsylvania School of Engineering and Applied Science. Postdoctoral training includes pursuing a master's in medical management from the American College of Physician Executives and serving on the American Cancer Society Fellowship in Medical Oncology and Medical Oncology Fellowship from Vanderbilt University Medical Center. So, I think your mic should be on. Deborah, would you like to start?
Sure.
Okay.
Hello, everyone, and thank you for allowing us to speak with you today. One of the things that I wanted to talk about is, first of all, how the impact of education can impact health. You know, my background has been an overlap of working in private industry, nonprofit, and academia. And one of the things that, is it not on?
It's on, but it's on.
Oh, I'm sorry. Okay, how's that? Can you hear me? Can you hear me? Probably if I speak without it, you'll even hear me even better. So, can everyone hear me?
This one.
Is it on? Are we good? Okay. A key social determinant of health is naturally the availability of quality education and training across every learning level. And I believe that's the case from, you know, early childhood all the way through retirement. A lot of times when people think about education, they think about, well, there's the K through 12 segment, and then there's the post-secondary or college education. One of the things that I think Penn State does well is look at the continuum of education from not early childhood, but youth academic programs through continuing education. Some of the things that fall under my purview include youth academic programs, and then there's the non-traditional learning piece, and then continuing education, workforce development, customized training, that kind of stuff. One of the things I think we have to keep in mind with regard to poverty is in addition to, coming up in a life of poverty, any one of us in this room could experience situational poverty, catastrophic illness, job loss. Those things can contribute to poverty. Most of us live within our means, but if you think about it, especially, single family income, or there's single income families have the possibility of at any given time being put in a situation of poverty. So we have to consider beyond post-secondary education, upskilling, and labor force training. I recently participated in the Allegheny Conference study. It was a workforce demand study, an inflection point study that looked at what they consider to be somewhat a crisis in particularly southwestern Pennsylvania, but I'll include western Pennsylvania. But there's an issue with backfilling jobs in the labor force because of a growing number of retirees. Baby boomers are retiring. And they also looked at what is necessary to train our youth or people at a college level who are already in school, or people that are downsized out of companies or dislocated workers, to meet those workforce demands. And it was a little bit bleak because they were looking at kind of a huge gap. One of the other gaps that exists is the communication between the actual industry players and higher education and technical schools, because a lot of times, it's driven by assumptions. And it has to be research driven, and we do rely on industry to dictate what we should be doing. So this study was pretty critical. And more recently, Beaver County has decided to put together an organization that kind of mirrors the Allegheny Conference with regard to, uplifting the quality of life in Beaver County. Just a couple comments. I'm a nerdy economics professor, so I have to throw out some statistics. The National Bureau of Economic Research shows that an additional 4 years of education, whether it be college or technical training, can decrease mortality by 1.8 percentage points and reduce the risk of heart disease by 2.6% and diabetes by 1.3. So when you think about, a lot of people don't think about how education can impact health, but it does. Not only in those ways, physical, but in terms of psychological, emotional, and sociological health, because people that cannot make family-sustaining wages might not necessarily have access to good health care. And we've talked a lot about that this morning. So that's something to keep in mind, too. I don't want to absorb all the time, so I'm sure we have some questions, but I want to turn this over to the other panelists to share their information as well.
Good afternoon. My perspective is going to come from my work within the community. And I'm reminded of a quote that Dr. Cohen said from Sharon Regional: "Them that have the gold make the rules." And that's what's happened to our local community. Those of us who think we know have made it difficult for those in poverty to come out of that cycle. One of the things that I always said when I was working at the Urban League is we cannot solve poverty. We must make it available to individuals who can come to the table and talk to us to let us know how they feel about being caught in that cycle. So my focus and my concern while I was working and even up until today is we need those people to tell us what they really need before we start making our own plans on how everything should go. We used to do a poverty simulation. Some of you might be familiar with that, where you would stand in the shoes of a person who didn't have the big money, the big salary, and you had to spend your dollars based on what they had to make it through the day. We don't see the upper echelon individuals of our community participating in these type of projects, and I think that's something that needs to be looked at, because in order for us to understand a man's plight, we must walk in his shoes. That's my connotation of how we can help address some of the people who are in poverty. I believe the last statistic in Mercer County for 2013, poverty level in Mercer County was 17%. That's a lot of people. But in order for us to make a change to our community, we must hold hands together. And that does involve collaborations. And I've heard it said that there's a lot of duplication within our community because of food programs, whatever it might be. But here's my perspective. One agency can't serve the whole population, number one. Residents that live in certain areas of the community can't get to certain places, number two. So that puts a strain on them trying to get access to one place. So we have to take a look at all of those different pieces to help us decide what is the best avenue for us to take when we address the issues that we have to deal with coming forward. I agree with Terry about the whole thing about agencies can never end poverty. That is a misnomer. I've always said that. We can help people, but until we can change the mindset of that individual, our work is not done. They have to change themselves. So we have to find out a way to really reach that person to make them feel that they are special, that they can make a change in their life so they can lift themselves out of poverty. Here's my other thing that I always say. If I was in poverty and on welfare, I wouldn't want a job. Why would I take a job for minimum wage and lose my benefits that my family and children need so I can become a productive citizen? Just think about that for a minute. Not to be derogatory, but that's what we see in our society now. It's more convenient for you to stay where you're at because the system is going to make it difficult for you once you get rid of all of those benefits. So that's another thing we got to take a look at, because we must make it sustainable for that individual to take care of their family, go to work every day, have a reasonable income so they can get themselves out of that cycle. I always said we need people in poverty at our table, and I've yet to see that. Even when I had my board at the Urban League, we don't have the right people talking to us. So I think that's the most important first step for us to take, even as a community, even as an agency. We need to have those people who know better than we what they really need. My goal in life is to always try to make it a little bit better for somebody else, and I'm sure everybody out here has that same goal. We got to get to know who we're dealing with, where they live. And let me say this before I go. How many people have been to Farrell? Good. I say that to say this. When people talk about Farrell, it's always negative, but there are good people all over Mercer County, whether they live in Farrell, Sharon, Hermitage, Wheatland, whatever it might be. That stigma has to be erased. And once we erase that stigma, then we can make it easier for all of us to hold hands with everybody in our community.
When Mickey asked us to speak, at least I got a phone call from her, and she said, well, can you speak a little bit about the challenges? And I don't think the challenges are any secret, but you know, from a behavioral health perspective, we certainly have an opiate problem, and everybody knows that. We have a lot of trauma in our community. We have children who are traumatized daily. We have adults who are traumatized daily. And this affects how they interact with everyone every day and the decisions they make. We are struggling on the behavioral health side with a shortage of good psychiatrists who we can draw upon. We have a wonderful array of services. We have wonderful providers. We have Community Counseling Center. We have Sharon Regional. But on the behavioral health end, if we don't have psychiatrists who are willing to come to our rural areas, work with our providers, we're in trouble. And that's a problem for us. That's a problem for all small communities. One of the things I worry about, we were talking a little bit about at our table about this, is how do folks, we talk about folks with poverty, and you lay over the top of that someone who is addicted or someone who is really struggling with a mental health issue. How do they navigate our system? It's hard enough. I had a small bout of pneumonia last year. It was hard enough to navigate. How do I get to the doctor? When do I get to the doctor? What are my medicines? I wasn't feeling well. How about somebody who is hearing voices or who is still high when they walk into our office? How do we help that person get to the office? Transportation's an issue. How do our DUI folks get there? They don't have licenses. And how do we erase the stigma? As you so pointed out, how do we erase the stigma from these folks? We talk a lot about recovery. Recovery has to do with joining your community in the healthiest fashion you can and feeling good about that. And recovery is different for every individual. But in order to recover, you cannot feel as though you are stigmatized and different from other people. And also I worry about the coordination of physical and mental health services. I worry about our doctors not talking to each other, and it's not the doctor's fault. It's just how the systems and the silos exist. And so it's our job to continue to work on how do we bring those down so that the folks that we work with are able to access services and not put themselves at risk because their medicines are conflicting. One healthcare provider doesn't talk to the other healthcare provider. I think on a positive note, we have some great opportunities, as you said earlier, to work in early intervention, to work with our youth, to make them as healthy as possible. I saw many notes over there talking about our families falling apart. Families look a little differently today than they did many years ago, at least when I was growing up. I had two parents. We did not grow up wealthy, but I had both parents. There's a lot of kids growing up today with, as was talked about earlier, moms or dads who are working 3 different jobs. It isn't that they don't want to be good parents, but they're struggling just to pay the bills. The more we can invest in our youth and the younger that we can invest, the better off our future will be. And the last thing I want to say is, the best thing I think we can do as a group of people that want to work together is focus on what is working well. Look out and I see 170 people sitting in a room wanting to talk about how to make their community better. Every year at our annual Human Services Planning meeting, of the 3 counties that I have worked in, and I've come back to Mercer County because I enjoyed working here the most, and I saw the greatest opportunity for change here. There are more people that show up for those planning meetings, more people that want to help, more people here that want to make their community better than I ever saw in Erie or in Crawford. And it's no offense to those communities, those are great communities, but this community has been very vocal about wanting to make change. Mark Benedetto facilitates our Communities That Care group, and they do that at the Behavioral Health Commission. The room is packed. Change is on the horizon, and people just need to incrementally continue to work towards it and focus on the things that are working, not just on the problems that we face.
So many of you may be aware that the United States spends more on health care than any other country on the planet. In fact, our per capita spending for health care is nearly double many of the industrialized nations in Western Europe. And unfortunately, despite that high expenditure, our health outcomes are significantly inferior. In many metrics, we actually rank near the very bottom. We are 5th from the bottom in infant mortality. We are 6th from the bottom in low birth weight infants. We are near the bottom in premature deaths. Now, the good news is that there's actually a paradigm shift underway in the delivery of health care. And I'm going to toss out a term that you might be familiar with, and if you're not, you're going to hear more about it in the time to come. But the previous model of delivery of sort of episodic care and sort of spending a lot of money on acute illness and which results in significant situational poverty for folks that have high expensive medical bills. The new model of healthcare delivery is very patient-centered. In fact, it's called the Patient-Centered Medical Home, or PCMH, sometimes also known as the Primary Care Medical Home. And this model of healthcare delivery is slightly different. The provider, be it a physician or a nurse practitioner or a physician assistant, is sort of the conductor of the orchestra. But in this model, there are other very critical and key players that surround and embrace the care of the patient. And the patient and the family unit is really at the center of that care, patient-centered medical home. And it's those perhaps non-licensed or not prescribing providers that are really the key element of transforming the way that we care for our patients in our community. And we've talked several times today about navigation and care coordination. And in fact, collaboration and connection are the first two next steps that we heard about here. And I truly believe that in order for us to move forward as a community and to try to improve the health of our community, we need to begin to think of ways that we can collaborate, communicate, and navigate together. We need to break down the silos. I've had the opportunity since I've joined the Federally Qualified Health Center to meet many of you and the wonderful work that you all are doing. I think in order for us to grow stronger, we need to grow together. And really, I think this is a golden opportunity for us to really come together and, again, put our patients, our families, and our community at the center of what we do. I just have two other things I want to mention about situational poverty. A few years ago, the Harvard Law School and Medical School did a collaborative research and actually looked at bankruptcy filings in the United States. And more than 50% of bankruptcy filings in the years that they surveyed were as a direct result of high, expensive medical bills. The cost of medical care is outrageous, and the out-of-pocket expenses are only going to increase. We were talking at our table earlier how premiums for commercial insurance and Medicare are expected to rise substantially in the coming year. Everyone is facing higher deductibles and greater copays. And it's really incumbent upon us as a community to try to help to make sure that patients are healthy, they have access to care, and to keep them well so they don't encounter those large medical bills and expenses. In that Harvard study between the medical school and the law school, what we identified is we are creating a whole new category of poverty in the United States. And these are typically slightly elderly, widows, because men have a life expectancy that's shorter than women. And what we've actually created now are a whole series of elderly women who are living in poverty. They've had to give up their homes, sell off many of their assets to pay for and care for their loved one at the end of their life. I believe that we have it's an imperative opportunity for us to, as a community and as a society, to begin to have conversations about end-of-life care, to incorporate palliative care and understandings and expectations of how we want to live and how we want to spend our final days, and not to be afraid to have conversations about end-of-life care. And then finally, Michael, I'd like to tell you a little story about my trip to Farrell a few years ago. All right. You ready? Sure. So I was at the Cancer Center at Sharon Regional, and I got a phone call from one of the guidance counselors at the Farrell School. And it was October, much like now, like your shirt. And the students at Farrell had raised money, and they wanted to donate it to the cancer patients at our cancer center. And I went after work. It was a home football game over at Farrell, and I was greeted by extremely proud young men and women who have raised money to donate to individuals that they had never known or would never know. And the sense of pride and accomplishment that these young men and women had as they gave me the check, I could have put 6 more zeros behind it and it would have not meant more. And I think it's important for us to remember that the youth of our community are good people. Right. And yesterday we visited the Manchester Bidwell School in Pittsburgh. Thanks, Tom. What an experience. And to see those young people come in from their public school experience and to have the opportunity to participate in arts and technology and jazz and clay, and the looks on their face of the pride in what they were able to accomplish. And I would encourage all of us to don't disregard our youth. Their future is our future, and their future is bright. So, thank you.
We do have some time for some questions, a couple of questions. I guess what I would like to ask, because there's so much information and so much that we shared today, if we had to prioritize, I guess I'm hearing families and youth. Is that true? Do you think that's where we might want to begin something, or do you have some other thoughts as how? Because if we're going to collaborate, we're going to have to prioritize too a little bit and communicate, because there are multiple needs. There are a lot. Can someone address that or share a little bit of their thoughts on that?
So, shout out to Jim and the folks from the United Way. Earlier this year, I had the opportunity of participating in the Mercer County United Way Economic Summit. And I actually, as part of that exercise, had the opportunity to look at the impact of poverty on childhood health. And one of the takeaways that I had from that experience was the impact that poverty and the chronic toxic stress that is associated with poverty has on a child's health, not only during childhood and adolescence, but that impact carries forward well into adulthood. And quite frankly, the wealth and income, if you will, of a child's father is the single most important determinant of that child's success into adulthood. I was very blessed. I won the birth lottery. I was born into a wonderful, loving, supportive, nurturing family. But if the roulette wheel had spun differently, I may have been born into poverty. I believe that it would be important for us to, if we're going to, we have to begin somewhere, to include the effects of poverty and poor health on children and adolescents. And that crosses the spectrum of physical health and mental health and the potential for addiction. I believe that, again, our children are our future, and I really believe our future is bright.
Just to echo some of those other comments, I do think that it has to start with youth, because one of the biggest challenges that a society can have to manage is a group of 18 to 24-year-olds who are unemployed or underemployed and have never had any education. First of all, they're hard to identify, and once they get to that point, the challenge of trying to get them into the labor force through any kind of education is difficult. So I think one of the things that we really do have to consider is that early childhood component. And again, education really does impact both physical, social, emotional, intellectual development. So, you know, if it starts out at a young age and we have parents that support education, and it doesn't necessarily, of course I'm representing Penn State, but one of the things that we have to also reduce in Western Pennsylvania is the mill mentality. I think a lot of times, you know, a lot of Southwestern Pennsylvania families come from, a lot of our college students come from first-gen families that, you know, their parents didn't go to college. So there was that push to get a four-year education because we want you to have a better life than we did. But that is kind of changing based on some of the statistics that have been, recent statistics have evidenced that there are going to be more opportunities for individuals who have less than a four-year education, technical training. The jobs that need to be backfilled are coming from 4 very specific high-demand sectors. They include IT, which in some cases, the jobs that they're looking at don't require a degree. They require some technical training, certifications, business and finance, production and manufacturing, and healthcare. And when I say healthcare, I don't necessarily mean the higher level, but you know, those intermediary workers that, you know, maybe do home healthcare, or, you know, those kinds of healthcare workers. So I really do think there should be, you know, early intervention with regard to education. I think it can significantly impact someone, you know, for the rest of their life.
Mickey, I just want to add that since it's a new day, there's a new family structure. I think it's very important that we be able to reach the family first as opposed to the youth, because the family structure of today is nothing like the mother-father we grew up with. It's all single female head of households more than anything. So I think it's very important that the youth are our future. I understand that, but I think we got to figure out a way to reach these quote-unquote new age parents, to have them have the right mindset to help us educate their kids and the youth so they do become better and productive individuals. So that's a whole nother piece that, again, as a social service agency and any agency in general, you're looking at a whole different dynamic of a family structure, and that poses a lot of things we need to think about in order to change the mindset of the parent first, and then have that trickle-down effect for the youth. So that's very important.
No, I understand what you're saying, because I think, you know, again, with youth, some of their heroes and some of the people that they see, and we're so connected, you know, that, you know, I don't know about the Kardashians or whoever, you know, those, you know, but, or an athlete or something, but, you know, who kids emulate, look at, think about, you know, it's a different day.
Yep.
And I think one of the challenges we all have, I have personally, is how to connect with that day and not, you know, go down memory lane and thinking about, well, yeah, because my grandmother lived in Farrell too. Her house is 1016 Hamilton. Probably the next one to be torn down, okay? And we talk about the mill ethic. Okay, I get it. Father worked at Westinghouse, you know, mother didn't work. And, you know, back to the days of the Buhls, okay, well, my grandparents were leaving Europe, Eastern Europe, probably as quickly as they can, so that the next czar wasn't going to, you know, make them more peasant farmers than they probably already were. So they came here for a new life, you know. Couldn't speak the language, couldn't do some things, and some things that were still, you know, going on today, just a different way of looking at it. You know, were there problems then? Sure. You know, my mother's only sister died of diphtheria at the age of 2 back in the early 1900s because we had infection, we had problems, and the bills came along as Mr. Ousley and Mr. Griswold, Dr. Griswold, and all this. Same thing. Industrial accidents, same things. Different problems, but again, with the creation of the hospital, started to make some impact. If I were to look at this foundation, and we are, you know, very much in the infancy stage here, just babies getting started with this, just beginning. If we were to prioritize or try to think of a first step, I guess that's my challenge to the panel. I know Mary Ann was next on this. She was grabbing the mic there for a second.
No, you're fine.
But if we had to, we talked about who we might approach. Okay, so how could we do some continued outreach? And Michael, you mentioned about getting the people in poverty to the table. How do we start doing that? How do we do that? How do we get the youth to the table?
Well,
anyone
that's a
can
tough
answer.
question, but all of us, look who's here. We have educators, community leaders, mothers, fathers. If I see a young person or we see a young person, can we give them a word of wisdom and encouragement to maybe say to them, we as a community want to embrace you all a little bit better. We want you to become a part of us. Let's listen to their voice. We leave them out. There's so many people that we exclude if we never understand or hear from them, how can we make an informed decision? My experience at the Urban League, when the young guys would come in, some of them didn't even know how to put a suit on because they never had a suit. It's the small things in life that we, who are the adults and understand what's happening, we could pass a few things on to them that will make them think a little differently. I get that. That's my interpretation. When I was on the school board, I did the same thing. You have to instill something in them that somebody else can't do it. And it's our job, if there is not a father in the household, which we know there are a lot missing, for me, that's my job. My father instilled in me the work ethic, and I want to pass those pieces on. When I see young people in the church, on the street, there's something inside of me that makes me want to just say, how you doing? Let me help you out. It's those type of things that will make a change for all of us to make the world a better place. And that's just been my philosophy throughout my life. So it starts with us. We're the ones that make the change. It's not about money. It's not about prestige. Not about power. It's about what's internally inherent in our heart that makes the difference. And that's the way I feel about life and people. People can talk about me all they want, but if I can still smile, shake your hand, and walk away, I've done my part.
Thank you. Mary Ann.
One of the most powerful experiences I had was as a child welfare director. And one of my supervisors came to me, she was our foster care supervisor, and she said, hey, I'd really like to augment our advisory board with the youth advisory board. And I said, okay, what will they do? Are they going to meet and we're going to bring them pizza and we're just going to talk? She said, no, I really want them to have their input, and I really want to have their input, and I really think they can impact the system. It's a young, bright woman with a lot of energy, and I said, okay, Amy, that's great. Go ahead, start, let me know what I can do. I'll help you in any way I can. Told my advisory board, they were supportive, but I think they thought the same thing. This is kind of a perfunctory thing. So we had to figure out how to get the kids to the agency or where we could meet them. And I will tell you, it was one of the most painful to hear what they had to say about how we were running their system and how much our good intentions hurt them. We ended up, they wrote policies where it was appropriate. They talked to us about how maybe our foster care homes weren't as good. Sometimes we had wonderful foster parents, but sometimes it wasn't as good as we thought it was. And I think they drove home to us how important, whether or not they had been removed from their home, how important those family members were to them, even though those are the people who had turned their backs and hurt them. As a professional, I can't tell you how difficult that was to listen to. I see people in this room, the people that I know, have all spent their lives doing what we think is best for people. And I remember for quite some time sitting back and thinking, what have I done? So, but better to have heard their voice. They made the system better. They made me better. They made me a better parent. And they made me think of the constructs that I had lived with in my mind for so long. They made me reconstruct them. So it took a while. It was frustrating. They didn't always show up. They were defensive. They didn't want to talk. We pooed on them a lot, not intentionally. But wow, is that powerful. So whether it's gathering families and individuals who are living in poverty, or families who have gone through our systems, children, I think it's a great idea. It's a great investment of time.
So what I've heard, really, just to summarize that comment, is that we need to expand the group here. We need to bring some more people to the table to help us. What I'd like to do is there anyone in the room that has a question or a thought, comment? Yes.
I think one of the things I would just say, and I totally agree with getting the broader participation. But it's also just a recognition that almost all of us, I would assume all of us, somebody's paying for us to be here. And so if we're going to expand the table and look to bring in people in poverty, we have to be willing to pay them for their time. And if they're going to be the experts for us, we need to treat them like experts. And one of the things you said was, it's worth the investment of time. It is. It's also the investment of money and other resources. And I just want to put that on the table because I think we have to take that seriously.
Thank you. Thanks. Okay. In the back. Selma, if you...
I'm so excited. I hope I can get it all out and not take up too much time. But the one question that was asked, my name is Selma Sanders West. I served on Farrell School Board for 9 years. When I resigned, Mike Wright was appointed to my position. So we go back a lot of years. I'm so excited to have flyers here that I'd like to give to people. What you want to do, Deborah mentioned creating new types of jobs that don't require a college degree. Someone else talked about reaching parents so that they can educate their children. I have been in the Hershey area, and I'm currently working as a part-time instructor for Temple University Harrisburg campus. They've started a program at Temple called Community Health Worker Training Program. A community health worker is an advocate who is a peer who can reach individuals in their community and educate them on all of the issues that we talked about this morning. I have been okayed to start a program here in this area. They told me, can you get 10 students? I said, I can sneeze and come up with 10 students. So anyone who you know who is age 18, who is computer literate, and who's interested in getting 3 credits toward a social work degree at Temple, they can take the Community Health Worker Training Program. It is a free program. The textbook that we use was everything that was in this morning's workshop. And this is a program that's 8 weeks. When they graduate, they get a certificate. They can work as a community health worker. The salary in the Harrisburg and Philadelphia area is $15 an hour with benefits full-time, which is a lot for the single mom who's struggling to raise her family. So I have flyers here. I don't have enough for everybody, but please Google Temple University Community Health Worker Training Program. Thank you.
Is that? That's a tie.
I was just thinking about the comments from the panel that were disproportionately talking about an anti-poverty initiative. Our community is being completely eviscerated by an opiate crisis, and that is not just a poverty issue. That impacts all families, all ages, all family structures. I'd like to think that since, if you want to talk in terms of sociology, the family unit is the smallest building block of our community. So if maybe we focus on supporting and strengthening families, whatever their configuration, whatever their income. I know most of our districts are dealing with a lot of issues with bullying that is not specific to a particular class or to a particular community or to a particular gender. So I think some of the issues we're talking about needs to be not so limited to just a particular income level or class level. We need to look at it as a strength in terms of helping families strengthen themselves however they define their family structure.
Vicki, can I just respond to that for 1 second? I can't really address the issue with the opioid abuse. However, the bullying issue, I think one of the things that, we all talked about bringing people to the table and, starting with the youth and educating parents. But the one thing that, and I know, is it Dr. Garrow gave a great example about how just, something small can be so impactful. And I think one of the things that we can do as people that may not necessarily live in poverty, and I think Terry gave a good example talking about, somebody that's a peer that, encourage somebody to do something better. I think one of the things that we can do to start with ourselves is not only engage people to find out what it is they need, but encourage our children to appreciate that everybody doesn't have what they might have. And I think that's, it's one thing to, talk about the family level of people or the family unit of people in poverty, or to talk about children in poverty, but ourselves, we can encourage each other and our own children to, appreciate that everybody doesn't have what everybody else has, and to try to decrease that bullying.
I'd like to also respond a little bit to the opiate question. We do have an overdose work group. Kim Anglin, who's our drug and alcohol director, facilitates that along with Jeff Hanley. It is a work group. We're talking about solutions. We're talking about how to get our hands on this. I will say, Mark and I had a conversation today, and I think he summed up my feelings. There is no silver bullet. We work. We strengthen families as best we can in each of the areas that we work in. We provide opportunities, we provide intake, we provide, our treatment providers provide treatment, but as you said earlier, we can only provide the tools. We cannot make people go. They have to want to be there. I was listening to someone the other day talking about drug and alcohol and addiction, and it's addiction, it's not just the opiate issue. If you've been a CYS director, alcohol's been pulling kids and families apart forever. People die of drunken driving incidences every day. Opiates are horrible. Addiction is the problem. Strengthening the family is part of the solution. Treatment opportunities are part of the solution. Continuing to keep your hand out is the solution. Somebody said, I was listening to someone give a lead the other day, and they said, someone asked them the question about what do you think about people that come in and out and in and out and in and out of treatment? And the person said, I think that that's somebody that comes in and out and in and out and in and out of treatment, and our job is to keep my hand out. That's our job, to keep our hand out.
So about 10, 15 years ago, many healthcare industry organizations, including the Joint Commission, which accreditates healthcare organizations, instituted a metric to determine how hospitals and physicians would be financially rewarded. And one of the questions on the questionnaires that the patients were asked to identify was, how well was your pain controlled? And in response to that, there was a striking increase in the number of opioid prescriptions that were written across this country. And as a healthcare provider, I humbly admit that my profession and our profession has probably contributed to the crisis that we're facing today. I want to assure the audience that the medical community in Mercer County and in Pennsylvania and across the United States takes this very seriously. In September of this year, the state of Pennsylvania has instituted a prescription drug monitoring program, so that anytime a new opioid prescription is written for a patient, the provider that's writing the prescription needs to check on the database to see if that patient is receiving a prescription anywhere else. When the patient goes to the pharmacy will not dispense the medication until they double check that database to make sure that they're not getting prescriptions from anybody else. I think we in the medical community are coming around to recognize that we own part of this. And preventing people from becoming addicted, I think, is as important as anything that we can do to remediate once addiction occurs. I want to send a shout out to a colleague and friend of mine that I work with here in Sharon, Dr. John Gallagher. He's had a long-term affiliation with the Pennsylvania State Medical Society, and in fact, he is seen in the state of Pennsylvania as one of the leaders in helping medical professionals deal with and address the opioid addiction. Mary Ann had mentioned that addiction is not going to be easy to solve, particularly the opioid addiction. And I believe that medication-assisted therapy such as Suboxone and methadone and Vivitrol may be important adjuncts. But in order for us to help someone break the cycle of addiction, it really is going to involve an interdisciplinary or multidisciplinary approach where medication-assisted therapy is given in concert with drug and alcohol counseling. Either by themselves is not effective, and we need to collaborate and work well together to make that happen.
That's right.
Hi, I'm still stuck on what Dr. Roach said about the mill mentality. I thought that was brilliant. I think 30 years have passed and we still are waiting for someone to come in here and save us economically. And I think that a major focus of any funding needs to be on the development of entrepreneurialism in this community. And we've got that wonderful center over at Linden Point that is already providing some of that kind of training. But if we could address Mr. Wright's point about listening to people and enabling them to provide input on their own, I think we would find an enormous level of creativity at the level of individuals who have had to scrape by to make their families work. So I think the entrepreneurial spirit is alive and well here, but that we need to really pursue it in avenues we hadn't considered before. Thank you.
Along with, on the lines of the opiate problem, my next door neighbor, Miller Industry, just built a brand new plant, and they'll be the largest wrecker car carrier plant in the world. They're going to push out 150 carriers a week. Their problem is they can't get workers because they can't pass the drug test. And they put, in their whole plant, they designed it to do flat welding. They said, you bring me in a person that could pass a drug test, we'll teach them how to weld. And they tried that, and they can't get people to come in. Bill Strimbu told me that he has trucks sitting because he can't get drivers for his truck. And what Miller's going to do, because they can't get workers, is they're going to put robots in there to weld instead of our people in our community. So if we could get to that, get them off of drugs, get them labeled to pass a drug test for employment. There is jobs out there, and employers are looking for employees to work.
It is.
Dr. Guerra, this question's for you. At this time in the Sharon Regional Hospital or Sharon Community Hospital and Farrell, do we have anything in place for warm handoffs for when an addict is taken into the hospital by a family member or arrested at this time? Is there any warm handoffs that are taking place? Thank you.
Wow, that's a fantastic question and an extremely important question. So if I could summarize, and what we're talking about is, and the term that we use is transition of care. And when folks intersect with the healthcare system, whether it's through the emergency room, into the hospital, leaving the hospital to come back to the community, there are so many holes in the Swiss cheese that could line up that could lead to adverse and bad outcomes. And a warm handoff, or that transition of care where one provider at one sector of the healthcare system, it gives an explanation to the person who may be caring for that person at the next sector of the part of the healthcare sector, time and time again has been shown to be critical in driving forward health improvement for that particular individual. Our healthcare system is broken. It's siloed. I would like to tell you that we have processes in place that permit for a good warm handoff. It's been a long day. Warm handoff. Unfortunately, I don't believe that we're there. I think we could do far better. And this may get back to that component that we were talking about earlier for navigation, or the woman from Temple, thank you, the role that the community health workers could play to help in those transitions of care. If you bear with me, I'm just going to tell you one quick story. When I was in Maryland and chief medical officer of a large health system in the western part of the state, we saw time and time again readmissions from patients who left the hospital and went to a nursing home. And many of you may be aware that hospitals are now heavily penalized if patients come back to the hospital for a same diagnosis after discharge within 30 days. And very humbly, I didn't know much about nursing homes, so I got in the car and drove out to the nursing home, and I just sat down and I said, what are we doing wrong? The system is failing these patients and their families. And what I discovered is there were actually two sort of peaks in the readmission occurrences. One was within the first 4 to 5 days. And when we did a root cause analysis to find out what that was, it's because they didn't really understand the medication management. So we really focused on making a transition of their medications. And the second peak occurred about 14 days later, and the root cause for those readmissions really had to do with an exacerbation of the disease, be it heart failure or emphysema or a flare-up or exacerbation of their diabetes. And I just took a step back and I said, well, my God, if we just talk to one another, we would eliminate this. So we actually developed a program where we actually we called it our transitionist nurse that actually followed the patient across the continuum of care and was able to relate and tell the story to the people who were receiving it. And with the development of this transitionist program, we saw a dramatic reduction in return to the emergency room and return to the hospital. So I think that's a terrific opportunity. I think it's not unique to the Shenango Valley, but health systems across the country really need to start to look at putting the patient at the center of care as opposed to the hospital or the ambulatory care center or the home. It's all about the patient. So great question.
And I will say we have been, as a drug and alcohol agency, we aren't there yet, but we are talking with our treatment providers about being able to actually have hands-on and be able to meet someone in the ER if the ER calls and take them to treatment. But we aren't there yet. It's a little bit of a maze, but we're working on it.
Somehow I wrestled the mic back.
Oh, there she is.
Because I wanted to respond to Mr. Wright and to, is it Father John? Father Jonathan? Adam? Thank you. I just wanted to let you know that if you buy a Bridges book, I get a little something. If you buy a Bridges to Health and Healthcare, I get a little something. If you use Getting Ahead, I get nothing. So I can brag about getting ahead, and there's no conflict of interest, really. But I just wanted to say we pay people. That's our model, to come to Getting Ahead. And we get criticized for that. And, you know, even in a small town in Knox County of Ohio, letters to the editor. Why are people getting paid to come and learn what they should be knowing anyway? It's not an incentive. It's for exactly what you said. People get, a lot of times it's soft money, so we can't actually write a check, but they'll get a card, right, to Walmart or to wherever. And it's because that we want people to know how valued their input is. To you, Mr. Wright, Michael, there are 60 Bridges communities who have people in poverty at the table. And I don't know of any other work that can say that. So again, you don't have to be attracted to this, but what is going on? I was struck by, just as George says, one more story. There was a woman going through Getting Ahead, and she had 8 steps in her plan for sustainability in her life. Now, she can't say she's getting out of poverty, but all right. Now, this is a woman who smoked. We didn't even talk about the predators in our community. You know, the drug dealers are preying on people who are vulnerable. That includes people in poverty and people in other economic classes who have a vulnerability. You've got payday lenders. You've got buy here, pay here car lots. You've got a lot of stuff in the community where I can go and get that flat screen TV. People come to Getting Ahead. We do a debt to income ratio. They're spending $1,000 a month. They barely have $1,000 a month just on the interest for all of these predators that we allow in our society. You know, we want people to make good choices, but we allow the worst choices in town to surround that pocket of poverty. She smoked. She kept getting evicted because she didn't have enough money. She spent $300 a month on smoking. I thought number one on her list, and you know what? I was raised by an Italian mother and a bunch of nuns. Number one on her list should have been to stop smoking. You know what I mean? I didn't say it, but I wanted to say, this would solve your housing problem. Number 8 was to stop smoking. Number 1, I would not have thought of this. Get out of bed every morning. It's a different world. When it came to ask her, what does that mean? She said, I have migraines. There was a medical issue. Why does a 32-year-old have migraines? How many of you have heard of the ACES survey? If I'm a child from up to 18 and I have a parent who's in jail, I have a parent who's died, I have a parent who's addicted, I have a parent who's abusive, you got 2 or 3 of those together, there's 10 different questions that you're asked. If you have 2 or 3 of them, you're likely to have migraines when you're likely to have fibromyalgia, you're likely to have lupus, very young age, the disease comes on. Number 1, she had to take care of her migraines. Number 4, complete her 2 years, her 2-year college degree. Number 8 was quit smoking. I met her a year later. She was at number 4. She was graduating. She's still smoking. I met her 2 years later. She had a patch on. You know, I think allowing people to see their own lives and what needs to happen in the way that they think it needs to happen is valuable. And you cannot keep getting ahead graduates from wanting to get at the table. People get excited. They want to do something not just about their poverty, but for their community. They look at themselves as a contributor. For every 10, our data shows, every 10 people go through getting ahead, 3 want to get to your community table to make a difference. And lastly, all your ideas are so good. I hope there's going to be an investigative coordinating team that looks into where you want to go and what you want to do. So you speak to that?
There will certainly be a team. There will certainly be a team. I appreciate it. Sam, you want to? Sam will be our last.
All right, I get the honor. This is last is not least, or in this case it is. One of the things I wanted to say was this. Let me preface it with, I try and look in the mirror every morning and do an assessment. And I know I'm not looking at Brad Pitt. I'm looking at me. And one of the things that really disturbs me, and I think in terms of the Buhl Legacy Foundation or whatever, it really needs to be at least acknowledged, because I see it as the elephant in the room that no one has talked about. And that is that, you know, we all look at how can we spend money, where is it going to be applied the best? But one of the things that everybody in this room can do, and I wonder how much we do it, when I look in that mirror in the morning, I wonder how much I do it, and I'm not thinking about it. And Michael, I'm looking at you because we share a lot of similarities. And that is, let me approach it this way. Graduation each year at the local high schools. We see pages upon pages upon pages of some of our best and brightest and most talented kids. Donnie Perry says they can't pass a drug test. I think a big part of it is a lot of the kids that we're producing in this area, they're in North Carolina, as Terry said. They're in Florida, they're in California. And I realize that the big excuse we use is that economically we've gone to hell. But how many of us have told our kids, the best thing you could do is get the hell out of here? And I think realistically, we've passed that message on, even if it's non-verbally, that life is better elsewhere. What really started me to think that way, Doc Arrow, was this. My primary care physician did not grow up here. He pulled me in one day and said, I want to talk to you. And I said, why? And he said, I love this community. It's better than the community I grew up in. And he said, why is everyone in this community so depressed about what it is? And their outlook is so bleak. And he said, in my primary care practice, I could give antidepressants to 70% of my patients. Why? And so, I look at what can we all do that doesn't cost a dime, and that's maybe embrace the community that we live in so that our kids want to stay here. Because, my field is wrinkles. And, when I started, and I'm going to shut up, Mickey. When I started, if you look at society in a triangle, the strata society that supported us were those people 35 and under, and our elderly population was very small. That triangle's turned on its head right now. And our population of young people is very small compared to those of us who are aging. And most of us that are aging at this point in 20 years are going to be in the cemetery. And realistically, that group coming up is the future of the society we live in. And they've got to embrace this place. And I think it's incumbent upon us, if we leave nothing else as a legacy, is to say, you know what? This ain't a bad area to grow up in. I agree. That's it.
Thanks to everyone who attended today.